All right, welcome everyone. Thank you for joining us at KY Open today. In the chat, you should see a link to sign up for CME credit or to request a certificate of attendance. You can also go to that link there or scan that QR code, and that will bring you to the form that will assist with the CME. Also wanted to remind everyone that the KY Open has a 6-month survey. So in order to improve the quality of our educational series, we have made a survey looking back at the first 6 months of KY Open. If you complete the survey, you can enter to win one of 10 $25 Amazon gift cards. I believe, yes, Chris just put that link in the chat. It's also in last week's newsletter. So feel free to click that link or check out the newsletter and fill out that survey. We appreciate it. I'm John Lochner. I'm the Education Program Coordinator, and Chris Cook, the Treatment Program Manager. We're both here to field any questions. You can feel free to send us messages in the chat if you are experiencing technical difficulties. But if you have any questions regarding KY Open, or if you're having trouble with CE credit, you can email me directly. So my email is there. Looking forward to the next sessions for KY Open. We're going to be starting a 2-week series on comorbid alcohol use. And then following that, we'll do a 2-week series on comorbid tobacco use. So those are the upcoming sessions. Some Zoom session discussion guidelines. We encourage you to enable your video and keep it on throughout the training. Please stay on mute if you're not speaking to reduce echo or extra noise. If you do encounter any technical difficulties, you can let us know via the chat box, or you can shoot me an email. This is a Q&A, so we do encourage you to ask questions. If you feel more comfortable, you can put a question in the chat. But as a reminder, we do record these sessions, so if you're going to ask specific questions, we ask you to refrain from using any personal identifying information. I am going to launch a quick poll here. This poll is a 2-question poll, and essentially it just asks you which counties you live, work, or serve individuals in, and you can select all that apply. And then the second question is your profession. So I'll give everyone a few seconds to do that. All right, thank you for filling out that poll. Rather than share the results, since this is a Q&A session, what I'm going to do here is I'm going to call on people in alphabetical order, and if you could just say your name and where, or I'll say your name. If you could say the county that you're joining us from and your profession, we'll go and do that real quick. So I'll start with Cara.
I'm a nurse, a registered nurse, and I'm in Pendleton County.
All right, Emily.
Good morning. My name is Emily Sprouse. I am a social worker and care navigator in Madison County with the Healing Transitions program.
Erica.
I'm Erica, and I'm a nurse and care navigator with the Healing Community Study in Fayette County with BCN.
Erin.
I'm Erin, and I'm a recovery coach with Fayette County.
Gary.
I'm Gary, and I'm a recovery coach here at Fayette County for the Healing Community Study.
Hannah?
Hi, I'm Hannah. I'm a social worker and care navigator for the Healing Transitions program in Boyle County.
Jeannie?
I'm actually with all the state. I'm the assistant director with the Department of Corrections Addiction Services.
Casper?
I'm a recovery coach that will be serving Boyle County for the Healing Community Study.
Kelsey?
Hi, I'm a social worker and care transitions navigator at Baptist Health Richmond in Madison County.
Kanita?
Hi, I'm a psychiatric APRN. I cover Kenton and Pendleton counties.
Kelsey? All right, we'll move on. Laura?
Hi, I'm Laura Stinson. I'm an academic detailing pharmacist with the Healing Community Study.
Margaret?
Hi, everyone. I'm Margaret McLadry. I'm the project director for the criminal justice team in the Healing Community Study.
Michelle?
Hi, everyone. I'm Michelle Ruffalo, a psychiatrist with the Healing Community Study.
Natalie?
Hi, my name is Natalie. I'm a nurse and care navigator with the Healing Transitions program with Bluegrass Care Navigators out of Floyd County.
Peace?
Good morning, everyone. This is Julie. I am a data management specialist with the Healing Community Study.
Shannon?
Good morning, guys. I am working from Fayette County, and I am a peer support specialist and recovery coach working with the Healing Community Studies.
Sonia?
Hi, I'm with Mountain Comprehensive Care Center. I am the coordinator, and we are in Floyd, Johnson, Pike, and Belfry at this time.
Tom?
My name's Tom, and I am a peer support specialist with Isaiah House, and I also run a sober living house.
Right. Zach?
I am a recovery coach with Voices of Hope through the Healing Initiative, Fayette County.
Okay, did I miss anyone? Great. Well, thank you for introducing yourself. I'm going to introduce our speaker. Dr. Chris Stewart is an addiction psychiatrist who lives and practices in Louisville, Kentucky. He received his medical degree in 1997 from the University of Louisville. University of Louisville is also where he completed his general psychiatry residency and his fellowship in addiction psychiatry. Dr. Stewart currently holds the rank of associate professor with the University of Louisville Department of Psychiatry and Behavioral Sciences. Dr. Stewart is the director of the University of Louisville Physicians Outpatients Addiction Program, the Inpatient Substance Use Disorder Service at the University of Louisville Hospital, and the training director of the Addiction Psychiatry Residency Program. He is board certified in general psychiatry, addiction medicine, and consultation liaison psychiatry. And he is a certified group psychotherapist with the International Registry of Group Psychotherapy. So everyone, welcome back, Dr. Stewart.
Thanks for having me back. So yeah, I guess go from here, right? So assume everybody was here for the last presentation, and I'll get a little used to this. This is a little different for me. I don't recall doing anything quite like this before, so this is nice. Having a follow up to a talk. So looking forward to the experience. Again, this is just a slide talking about gaps and the needs that the presentation was based on. And again, obviously my talk emphasized the epidemic of polysubstance use in patients who are receiving medication for opiate use disorder. And I talked a lot about trauma and how trauma is a big part of that, as well as the multiple substances that patients are using. And understanding addiction as a brain disease is critical to really also being able to facilitate and help these patients get the services they need, and understanding them and getting out of sort of the past mindsets that we still struggle with, all of us do, around dealing with this kind of the problem of addiction. But, all right. Yeah. And there it is for you. So we can go on to the next slide. Yeah. Anybody has any questions about that, feel free. Okay, so again, you might remember this slide, which is just sort of a way of exemplifying the range of different substances and that are being used in our communities, and that are being used among the patients who are coming into treatment. We're seeing a different presentation maybe than we have, and that's pretty typical in addiction, right? We see trends. We see patients come in and present with, really a combination of substances that they're using. That's the norm. It's really not the exception, or we don't see people just using one substance. And so wrapping ourselves around that is important. All right. So again, the norm is the polysubstance use really with our patients today, not the exception. And most patients, again, who are being treated for MOUD, most are likely to meet criteria. And meeting criteria is important because it's how we kind of create a standard for how do we identify a problem. But it doesn't mean that if it doesn't meet all the full criteria that it's not a problem. That's sort of our benchmark. So meeting criteria for another problem is significant. That it's like they'll not only have one addiction, but they'll meet criteria for another one. And it's the experience of myself as well as others, and consensus as well as empirical evidence that supports that MOUD provides benefit in the population that are using multiple substances. It's not just reserved for patients who are only using opioids, and we don't provide it for people if they use other substances, right? We don't do that. And that it can facilitate treatment for other problems when there is opioid use disorder. So, and again, this is just a nice, these patients do have poor prognosis and poor outcomes when there's multiple substances or psychiatric problems. And I think another thing too, with co-occurring, dual diagnosis, all those terms that get thrown out, this is just another way of talking about patients who might be more ill or have more severe illness than other patients. These patients are harder to engage. Really, in all of our settings, they're more likely to present when they show up in the hospital. Okay. And these are, I mentioned these last time, considerations and relapse. We can say more about this as questions arise. And then again, my approach, I like this slide to sort of, it still for me sums up a lot of when I try to approach somebody when I'm treating someone for addiction, these are the things that I tend to think about. It's not obviously complete. There's going to be things that aren't listed here, but just an overall generalized view of what I do when I see somebody. Again, address safety issues, medical issues that are most pressing. In medicine, we triage. We take the worst problems and we try to then rank what's most important now to address, and then we go from there. And so that's kind of what this really represents. Attend to the medical problems, acute danger, issues with acute mental danger, suicidality, or severity that, anything that threatens somebody's safety from a mental perspective. And then from there, and then understanding that this person is traumatized, suffers from post-traumatic stress disorder, and also most likely developmental trauma, not just the trauma of their life now, but trauma that they've had throughout their life that has affected their ability to attach and interact with other people. And so that's going to be playing out when they're encountering treatment. All right. And again, so it's challenging. And again, well, sometimes, we get engagement, we get compliance. We might not always feel like we get recovery. If you get engagement, you're doing something. Compliance is great. That's what we can measure a lot of times in treatment, how compliant is someone with treatment. It doesn't always mean necessarily that they're benefiting or that they're getting something, or it doesn't always mean that if they're not completely compliant with treatment that they're not benefiting either. But it's just it's a way we measure treatment. We have, and that's one of the things we can concretely measure. So I like to include that. And yeah, recovery. That's a word that has a lot of meaning to a lot of different people, but it does happen. So what strategies do you use for patients that want to be treated for opioid use disorder, but are ambivalent about their other substance use? Well, it depends. But if someone is using heroin and is, for example, an IV heroin user, and they are wanting to be, they want medication for that. I don't know. It'd be pretty hard to say that they wouldn't be a candidate for it. They're going to be a candidate if they have a heroin problem and they want medications, or they're abusing opioids and they want medicine for opioid use disorder. They're a candidate, and you're going to start them on it. I'm going to start them on that. I want to know what other substances they're using, of course, because that does affect risks, like, for example, risk of overdose if they're using other substances that might interact. But by and large, most of the patients are still going to really benefit from medications for opioid use disorder, including methadone or buprenorphine, even if they are using other substances. And I think that's the kind of the point. So I'm going to not make any kind of conditions or demands on somebody overtly that I won't prescribe this unless you stop immediately, right? It's going to be more about, so I'm concerned about this other problem, and I'll generally say in my clinic, it's generally the rule or an expectation that you don't use any illicit substances while you take this. But I'm not going to end your treatment because of other drug problems that you have. And I'm not going to fire you as a patient for having addiction. If you're coming into my treatment program for addiction, I'm not going to fire you for having the problem that I'm supposedly trying to help you with, right? But as I have to be a physician, I have to manage risk and think about safety. So I'm going to do that, right? And if someone's drinking alcohol, that's going to be an issue that may require them to be in a higher level of care. I may not be able to safely start medication for opioid use disorder in an outpatient setting if someone's drinking a lot or taking a lot of sedatives, where I'm worried about, I'd be worried about their safety anyway. But for patients who are doing methamphetamine and opioids, which are frequently used together, a lot of those I think can be engaged in outpatient setting. But, just like I said before, I'll approach it, look at the safety issues, consider what level of care they need. That's really important. And then try to meet them where they are. Sometimes they don't want to go to the level of care. So say again, requires clinical and individual judgment that manages risk, right? In general, would share expectation. Oh, so who's typing that out? Who's doing that?
So that's Chris Cook. That's the treatment program manager.
Oh, wow.
Yeah, that's me. Sorry.
All right, that's it. Okay, great.
He's just taking notes while you get the questions.
Okay, that's interesting. All right. So yeah, what are other people's thoughts about this? It's a good question. So fairly non-controversial a position in this group, I suspect. So we can move on if nobody has another point to make about it. I mean, ambivalence is normal, right? We've all been trained about that. We want to assume, so we don't have a strong reaction to that. We want to be, we want to normalize that. Yeah. So we can move on unless somebody has something they want to jump in on there. Are there ever situations where you triage multiple use and focus on one disorder, right? Let's kind of piggybacks on this last question. So, of course, triage is a good word. I mean, yeah, it happens all the time. I'll always probably focus on the thing that's going to kill somebody or to be the most dangerous or the most lethal or the most pressing issue, And so when someone's using opioids and there's a risk of, particularly with fentanyl, and we're worried about death, and we know that every time they use IV especially, there's a risk of overdose death, unintentional. And that patients who use successfully, if you will, or without causing overdoses, doesn't mean that they won't have an overdose the next time they use. And so I think it's justified in really emphasizing that we need to then, really focus on patients who are doing things that are dangerous and the most dangerous behaviors. And I guess some people call that harm reduction, but I think just, it's not even really, it's beyond that. It's really, what's the most dangerous thing they're doing? And then that includes, I might have mentioned before, situations that people are in too, not just the drugs they're using, but if they're in dangerous situations that they need help with. Working with populations that are being subjected or victims of human trafficking is really challenging, but also really important to recognize when. And I think that I have a pretty large, broad net over that group. There's, lots of different, there's a spectrum of this problem, but I think if someone is in a situation where they're being exploited, which many of our patients are, then that one is to think of, that one's important to help the person with in some way or try to engage in that way. That usually requires a lot of trust. And is another reason to think about level of care, where someone needs to be in a safe program because they need to really be out of the situation, not just because of the drugs they're using, but because they're in danger. Yeah, a lot of addictions can be managed at lower levels of care, at least even from a harm reduction standpoint. I think, it's more about getting somebody to stop using, sometimes requires some higher level care, but detoxes can be an issue. Certainly alcohol withdrawal is dangerous, and sedatives, Xanax, benzos, is another reason why you're going to think about needing a higher level of care, that you might have to think about getting somebody treatment immediately for. But these options aren't always available. We're often dealing with situations too where we don't have access to the best level of care, and we have to use what we have available to us and help patients just however we can. I don't know if I think about it as consciously as I probably need to, but I'm used to it all the time, dealing with a situation where conditions aren't optimal, for treatment. You're trying to make the best out of a bad situation. I'll say psychiatric conditions, obviously psychosis, mania, people who are acutely disturbed and need to be admitted. That's obvious, right? That's maybe not, but that's going to take precedent too. Sometimes with methamphetamine, we'll see patients who are psychotic. We'll have patients who have psychotic disorders and then they use drugs and they make their illnesses worse. But we also have patients who cause these kind of symptoms from the drugs that they use. And all those patients, regardless really of why, if someone's acutely psychotic, they generally need to be in a hospital if they're, at all dangerous to themselves. Particularly in the meth, it's not going to resolve in a short period of time. It could last for a while, and so they're going to need a higher level of care for that. And so you might focus on that when you're seeing somebody who is not in, it's obviously not coherent enough to participate in traditional type of outpatient treatment. Okay. Alcohol and buprenorphine. Buprenorphine by itself is not really, as far as I'm aware, there might be an isolated case, but it's not responsible for causing overdose death. You can overdose from methadone, and there's a risk when people start methadone early on in their treatment, they have increased risk of death from methadone overdose when they first start. But otherwise, taking buprenorphine and methadone significantly reduces overdose death, which is why we push on this so much. But there are overdose deaths that have included buprenorphine as a drug when they're combined with other substances, especially what we kind of think of as sedatives. And opiates and sedatives together do present an increased risk of overdose death, as well as, and including alcohol in that. So alcohol and sedatives is certainly going to complicate maybe initiating on something like buprenorphine or methadone. And it might also, if you're at the level of care, that would be nice. Let's say you're in a higher level of care. So you're at a detox and someone comes into the detox setting and they are coming off of a combination of sedatives and opioids. Well, you've got possibly some other options like other drugs like naltrexone, depo-naltrexone, which is known as Vivitrol, is something to consider. In somebody who might have a combination, that does, I don't know if it complicates it, but it might affect what choice of treatment you provide. Certainly, we see patients. This is probably not totally related to this, but in the SUD service, we have patients who come in who have really severe medical problems, and they are addicted to heroin, and they've got endocarditis, they've got sepsis, multiple severe medical problems as a result of that, abscesses, and they're in pain and they're on pain management in the hospital. Well, those patients can't just be switched to buprenorphine, because if we tried to do that, they're going to have pain and they're going to you could precipitate withdrawal, or they're not going to be able to tolerate the period of time they need to be abstinent to be inducted on bup. So a lot of those patients are better candidates for methadone maintenance, and we'll start methadone treating their pain in the hospital again. So then that affects your choice, which we then want to coordinate methadone maintenance when they leave the hospital. Well, in some communities, methadone is not really as accessible. And so that can really be a problem if you've got this situation in a community where you don't have, the patient doesn't have realistic access to methadone maintenance. That's one of as far as other substances go, you might want to think about buprenorphine in a case where you were concerned about overdose and if someone's mixing other substances. I think if you had to pick between buprenorphine and methadone, buprenorphine is probably a better choice. But also, if someone does have chronic pain, methadone is probably a better choice for that patient. Again, those are just some of my thoughts about that.
Does anybody else have any thoughts about this question?
Are the substances that can cause side effects to MOUD? Are there drugs that can interfere with or cause side effects? So if you're taking, if you're, you know, I think about MOUD are 3 medications. I think about methadone maintenance, buprenorphine, naloxone, or buprenorphine, and naltrexone primarily. Those are the 3. And either any of the, we could talk about Sublocade, but it's a version of buprenorphine. So to think about that one, side effects as opposed to, certainly we think precipitated withdrawal is a side effect. So if you're already on buprenorphine and you take opiates, nothing's going to happen. But if you're already taking, if you're taking opiates and you take buprenorphine while you've been habituated to opiates, you're going to have precipitated withdrawal. But as far as substances that add to the side effects, I think, you know, you have to think about if somebody's taking other substances, the main issue there is they're still activating the parts of their brain that are what we consider to be operational in addiction. So there's something I think important about getting someone to stop sort of massaging the part of their brain that is activating their dopamine system. And so if they're still using other substances of addiction, they're going to interfere with their the efficacy of the treatment. I don't think that's what the person's asking. Constipation is a real problem with buprenorphine. So if you're taking other medicines that can cause constipation, that's something you got to pay attention to, because that can be a real chronic problem with patients who are on, you know, either methadone or buprenorphine for long periods of time.
Is there,
yeah.
Can I ask a quick question? Dr.
Sure.
Stewart? So I'm curious, we have a lot of peer supports here with us, and I think nurse navigators that are in the field kind of having interactions with clients. And I'm just curious, are you guys hearing like from clients that you're working with, are they worried about side effects of buprenorphine or methadone with other stuff, or just in general? Like Dr. Stewart might be able to provide some insights that could be helpful to you in your work. So what you're hearing.
I did have one patient actually yesterday who had mentioned that he had heard, and I don't know if this is true, that low testosterone is a side effect of buprenorphine, but I didn't have any information to give him on that at that time.
Well, opioids as a class will cause problems with sex hormones and suppression of sex hormones. Dr. Lofwall can jump in on that one too. That's a side effect of, I think that's certainly something we monitor and can be a side effect, you know, of just opioids.
Yeah, exactly. So Dr. Stewart's correct. And we think that that's more of a concern with full agonist opioids than partial agonists. There've been like several studies out there. It's really uncommon that you're going to see it on someone on buprenorphine maintenance, but if you have someone who's having symptoms and that, then it is something that, you know, they should let the provider know, and they can check their testosterone levels. Usually what happens is people's kind of whole hypothalamic pituitary axis and sex hormone axis gets like totally messed up when they're actively using, and, you know, like on and off and short acting opioids. And they frequently, like the women will have really irregular periods, and some will think they can't get pregnant. And then, you know, they'll come into treatment and start doing really well. And then all of a sudden their cycles normalize and they can very easily get pregnant. So, there's something about the way in which people are using the opioids too, and the half-life that's important. What else are you guys hearing? That was a great comment.
Very good. Anybody hearing anything about blood sugar or sweets or glucose or cravings for sugar? Guess not. There can be some association there with opioids and glucose metabolism and problems with that. But
I got a quick question. I'm sorry, this is Shannon. So a lot of my clients that are on, well, a lot of my participants that have the multi-substance use, it's with the stimulants. They're like, that's all they crave and want is sugar with the stimulant. Is that I don't know medically like how that affects, but
Well, carbohydrate craving after you've been on stimulants, I think about that in terms of, when you're coming off of methamphetamines and you crash, and, they are an appetite suppressant, amphetamines are. So then the, flip side of that, I don't know specifically about the endocrinology behind that. There might be more to it around specifically why, methamphetamines and sugar cravings. But I think about it in terms of dopamine. Patients who eat sugar get a dopamine rush from that too. It's another way, that patients will sometimes manage the post-acute withdrawal for lots of different substances. But you're saying specifically to stimulants. I think about it in terms of, they've been starving a lot of times, or, and so they're sort of reeling from that. But any thoughts, Dr. Lawfall? Are you out there?
I'm out here.
What do you know
I
about
think you're
amphetamines?
right. No, I mean,
Yeah.
I think you're right. I think I don't know the endocrinology either and haven't looked it up. And I thought, oh, I should maybe look it up now, Shannon, because it's a really interesting question. But I think in general,
yeah,
the psychiatrist's kind of quick book to everything is, and it's really true, is that you get the opposite effects when you stop use and you're going through withdrawal. So what Dr. Stewart is saying, the anorexia and the appetite suppressant effects are all there when the person's using, and then when they stop, the opposite happens. And so, the body, I think just normally evolutionary, if you think of evolution is if it's starved, it's gonna want quick fuel, and simple carbs are a very quick fuel for the body. Not the healthiest always, but.
Right. With bipolar disorder too, you see people when they come out of mania and they get depressed, the classic depression where we think not atypical depression is associated with cravings for sugar and wanting to eat a lot of sugar. It's really interesting. Yeah, I'm going to have to look that up myself.
Great. Does anybody else have any questions about side effects, not just with MOUD, but other substances that they're hearing about?
It's good point. Just or anything else that's come to mind from these questions too. It's not only it doesn't have to be precisely related to the question. So.
All right, we'll move on to the next question.
So yeah, this came up, to me, when I see clinically somebody using kratom, kratom to me is just another opioid, really. And when people are in withdrawal, it's an opioid withdrawal. It's a little different because it has some stimulant properties. And, but I'm going to use buprenorphine, and there's some literature that supports the use of buprenorphine to treat kratom. There's a sense in the community, and I'll hear this, just heard it last week. My boyfriend is using kratom to stop heroin use, and he's taking kratom and he's going to taper off, and then his plan is to be off kratom and he's going to stay clean that way. This patient, and I'm like, well, that plan, I have never seen that work. And I'm sure people have stories where they say, yeah, it worked, but I haven't seen that. And I haven't seen anybody who did that. Let's say they did the kratom and they tapered off, who stayed clean. I've not heard that story. Now, I may not be the guy who hears that story either. But what I see would be escalating use. I started going to get kratom. I had to get more. I had to buy more. I started getting sick when I didn't have it. And, it's been used just like an opioid. And pharmacologically, it is. And I do test for it in patients who are coming into the clinic. Sometimes patients will want to supplement and they think, well, I can do this. And sometimes they'll innocently think that it's, it's legal. It's something I don't even need a prescription for. That ought to be okay. And explicitly will expect, no, this is a substance that is not a good thing to use with opioids and bup, and it's interfering with your treatment. So, we don't want you doing that.
I know I'm not supposed to have questions.
Oh, you're not?
I don't know. But is there like a reason that it's legal or not, like a scheduled thing? Does anybody know? Is it just new or?
It's not new. It's been around a while.
Michelle says I'm allowed to ask
you're
questions.
definitely allowed questions. That's a good historical question. Like, why is kratom, not, I think, like a lot of things, it comes in through, we created this avenue for things to come in that are natural and, don't have a lot of history of problems. I mean, there's not a huge history of kratom addiction. And maybe before we had an opioid epidemic, it wouldn't have been maybe it wouldn't have been an issue. Like there's things you can get supplement wise that aren't good for you that could be potentially habituating. For example, Phenibut is something I still see from time to time. That's very dangerous. I don't think kava kava is a good idea for people with addictions, but you can get that in everything. And valerian, and I've seen problems with that, but nothing I think kratom is on a new level, and there's it's in head shops, right? So they recognize that there's some kind of, it's special. But I think it's a really good question. Does somebody know the answer to that here? It'd be great to hear.
I think it was on the DEA list of drugs to consider to schedule.
There's some places where it is.
Yeah.
Some states have already gone ahead and said, hey, you can't get this.
Yeah.
I don't think there's any medical benefit from whatsoever that's designated by this either.
Yeah, you're right about that. It's interesting. I had a patient who used kratom to attempt to come off of buprenorphine. He'd been a patient for almost a decade and was on a really, really low dose of kratom and was just like sick of coming and, was employed, smart guy, looked it up on the internet, college, finished college, all that. And, had been in remission and recovery for a long, long time.
Right.
And he was like, it was legal. And so he went to head shop and got kratom as like a powder and was drinking it, according to how it was supposed to be dosed, because he read it had opioid properties and thought it would just be a little bit easier. And he did not do well, and so he ended up coming back and, he stopped the kratom, and then we actually put him on Vivitrol. So it was interesting. He went from, being a patient who was on buprenorphine for close to a decade and kind of very slowly tapering down to, getting fed up with just having appointments, to self-treating with kratom. That went south, came back, but then went on to Vivitrol. So, but there had to be a period of time from the kratom to the Vivitrol because we didn't want to precipitate withdrawal because of that opioid property.
Is he still on Vivitrol now?
No, he's done with the Vivitrol, and the last I heard, he's doing well. I think that's always the hard thing, is that when people kind of quote graduate or whatever, lots of times they don't keep any contact with you, even though we try. We try and sort of say, like, treat ourselves like primary care docs, be like, just come in, check in with us. But
right, we'd like to see you, just to see if you're doing well.
Yeah. But like a lot of my patients will just say, I'm ready to change the channel. I don't want, and I don't need this, you guys on my channel anymore. So.
Yeah, that's interesting. I always had I told lots of patients that who wanted to get off buprenorphine one day in their plans, right? Lots of patients have that. I don't want to take this forever. I don't want to be a hostage to treatment. I feel like, that wasn't what they were thinking about when they were doing heroin per se, although they felt like a hostage then too, but it's different. They come into treatment though, and they start to think, I don't want to have to depend on this. I want to be free, and they don't like the stigma. And we would always say, well, I think if you're going to do this, the way you do it is you get a taper off and then get on Vivitrol. And nobody ever took me up on that. No one's ever taken me up on going to Vivitrol from buprenorphine. Nobody's been able to tolerate the withdrawal from the buprenorphine so far that I've had. My hopes are that I don't have anybody yet, but I'd like to try the depot buprenorphine in tapering people off. And some of my patients are interested in that. But I've had a few patients who tapered off buprenorphine, and like you said, but none of them wanted to take Vivitrol after that. They just tapered off and went on. But only a handful of people have ever done that.
Yeah, I always thought like that would be something that would happen as well.
Oh.
And it just hasn't come to fruition. And he's really my only person. And the other people who I've had go to Vivitrol that are on buprenorphine were more like, buprenorphine really wasn't working well for them. Not that buprenorphine was doing so well and they were super stable and they kind of gently came off and then wanted, Vivitrol as kind of like an insurance policy. It just didn't go like that.
All right. Well, go on, John. Go to the next one if you want. Okay. What treatment options are there for depression and anxiety for people on medication for opioid use disorder? Yeah. Well, most of our patients who come in for this are going to have problems with mood. And that involved either being depressed or having anxiety or a combination of the two. A lot of different anxiety disorders, types of anxiety problems. Some of it you think, well, is this related to the drug use, and will it get better with ongoing abstinence from the drug use? Some of it was before they started. Some of it was aggravated by all of that, right? All kinds of combinations, but engaging them in treatment also addresses these problems. And that's why I like to really strongly encourage, almost require everybody to do counseling on some level when they come in, and try to get them accustomed to seeing a counselor, not just me, but seeing a counselor on a regular basis. And sometimes the counselor just is in checking in with them and helping me monitor them. And we'll say, well, this is just to monitor, but also it's really to sort of get them used to talking and engaging in the process of psychotherapy and talking about mood, talking about things. Many patients with addictions don't think about or reflect on or mentalize themselves in that way. So learning how to do that's a skill, and teaching them skills about how to deal with their feelings, right? That's basic addiction counseling in a lot of ways. That's important, and that helps with depression and anxiety. And then many times these patients really do benefit from psychiatric medications that help with mood by somebody like myself or a physician or somebody who has experience with addiction. And so many of us, many of the patients in our clinic are on other psychotropics. You can, and again, I've talked about PTSD. I think, in my opinion, I'll say it's my opinion and experience that the majority of these patients have problems with mood related to post-traumatic stress disorder and developmental trauma. And so to me, the real treatment for PTSD is psychotherapy, being safe, learning how to feel safe again, and even learning what that is, what they've not even been aware of. And then medicines for mood disorders sort of kind of come on top of that and ultimately treat the symptoms a lot of times, not the underlying issue, which is hard to get to. And sometimes you're not going to get to it completely or totally resolve it just by using this approach. But in some cases, it's at least potentially a curable problem, as opposed to something that's like schizophrenia or classic bipolar disorder, which we think of more like in terms, this is chronic. It's not going to completely go away. We're going to manage it with medicine. For a lot of people with PTSD, it's also chronic, similar to that. But there are patients who grow and really can come out of that place and their lives can really be radically different. And sometimes in previous systems of care that's not possible. That's possible with this type of treatment. And that's all I have to say about that.
Does anybody have any follow-up questions or thoughts?
Well, I'm just curious if for our audience, is any of that surprising to hear?
Probably.
Were people expecting that there would be like kind of like just a medicine that would really make things be all better for someone who has PTSD and extensive trauma? Or is it not surprising to hear that there is a really important component of therapy? Or what are you encountering, and what's we haven't spent a lot of time kind of talking about that within the HEAL. So this is a really great opportunity to really pick Dr. Stewart's brain. He's an addiction psychiatrist, and he's led the training program for addiction psychiatry at U of L for many years. So there's not that many training programs, and he's really good at making complex topics simple. So I just want to make sure that everyone's taking advantage of what he's talking about, because I think you're going to get really difficult questions or complex questions from family and friends as you're trying to help people navigate the treatment system. You might hear complaints or concerns about what someone thinks is the right thing or the wrong thing. And so he might be able to help address some things.
And the next move is we'll start picking on people, right?
Yes, yes.
Is this the last question? Is this the last one?
I don't think so. I think we have more.
Okay.
Chris Cook, you need to ask a question.
Oh, picking on our treatment team, I see. Okay, well, give me at least like 1 minute or one other question to think of a new question, and I will.
All right, there you go.
My name's Tom. I got a question. I've heard or I've seen on different webinars, and I've seen this for the long run. It's been important about the connections and the and a lot of people are saying connection is the opposite of addiction, and it has a lot to do with, I guess, with maybe rebuilding parts of the brain that that opioids have destroyed or hurt, or regrowing some of the pathways. And I've heard that on a lot of webinars. I've actually seen some from Hazelden and a couple others where they're making the point of being able to saying that you should be connecting with the same providers, because they do build connection. And I think in one deal, I don't even remember where it was, but they were saying that in their clinics that they were introducing people that were coming in every week or so to everybody on their team in case somebody was out, on vacation or left the company or something like that, that the person would be able to connect and be more open because they had already met the other people. And I'm just wondering, how that connects, to be honest with you.
Well, thanks. Tom? Yeah, thanks, Tom. That's a great point. I mean, I'm a group therapist. I think of myself like a group therapist a lot of the time. I don't run as many groups as I used to. But I think that's also sort of the rationale for why we use group, or one of the rationales for why group is helpful in addiction treatment. It's really important, right? I mean, that's what we're trying to do. These addiction and isolation go hand in hand, I think. Although people do have relationships in addictions that we have to also address when they get clean. Healthy relationships, mutually satisfying relationships. And I think until an addict learns to develop the ability to have mutually satisfying, healthy relationships. They're always vulnerable to relapse. They're always vulnerable to relapse, but they're really vulnerable without that. And so one of the skills is how do you teach people to form supportive relationships. And you're dealing with attachment trauma. You're dealing with wounded attachment when you're dealing with patients with addiction. They've had, abandonment, abuse, neglect, addicted family systems they often come from, where they have suffered from those systems, and they may not even be aware of that has an impact on them. So I think that's a great strategy to bring in and have them introduced to the team, and that builds resilience in the treatment too. Like, you're going to know everybody on our team, and people are going to know you. You're going to feel known by everybody here, and in a way, we're going to be holding you in treatment because you're going to be known by a team of people. It's not just one person, although that's really important too. And I've seen the same thing that, and have seen in presentations as well as read about opioid receptors and dopamine receptor density in children and primates too, who have been in situations where they weren't, where they didn't get support or enough nurture, secure environmental support for growth for when they're children, and that they can lack the ability to they lack the capacity, or they just have a diminished endorphin system basically, which might make them more vulnerable to using opiates later on. That's certainly been a theory, and I think that has merit. But I mean, I think the ability to soothe yourself and is greatly enhanced by engaging in groups in a healthy way. And I think that's why 12-step recovery is so helpful too, as well as that's why peer support is so important too, because you need people who are authority figures in your life. You need peers. You need, you need a structure that's stratified. I think it really does help. And having people that you really identify with right now, who are going through what you're going through, as well as maybe people who've been through it already and got to the other side, and then professionals who are helping you. I think all that does a lot to reassure somebody that they're being cared for. And also they feel, that's a feeling too. It's not just, I don't learn something, I'm having an experience when I come in, and I have lots of people that are, maybe glad to see me. That makes a difference.
This morning, before I left work, we were checking people out, checking their property out and so forth, because they graduated. And there was one little box was just sitting there, and I said, "This has been sitting here a while." And they said, "Oh, well, he overdosed and died." I'm going, "What?" And the guy had just been in there, and this is maybe just me because I'm not actively involved, in the treatment part of this, because I'm in admissions. I do a lot of talking to people on the phone, about connections and getting them in, doing the the evaluations up front. But this, I may be wrong on this, but it just seems to me like, as long as everybody's kind of connected, to the group that they're coming out of, they're fine. They're going places together, they're talking together. But then as they move off further and further toward home, say where they're in Eastern Kentucky and we're in Western Kentucky, it's just that, once they get a little bit away from the culture and they go back to something more normal to the way they grew up, boom, they're right out of there, unless you're on buprenorphine and so forth. And that really shocked me, that less than 20% make it 90 days if you just taper them straight off. So I don't know, I got a lot of questions about that, but it's also a passion for me to learn more and more about that, because I know that over the years of sponsoring people and so forth, keeping them connected, introducing them to other people and so forth, all over NA, Celebrate Recovery, and AA, seems to be more effective than coming out of treatment centers and not integrating them into those 12-step groups. So anyway, I just, a lot of questions still on that. Thank you.
Yeah, thanks a lot for that's a great point. I would say it's so important. And I think it's also like, what I think about it too is, it's like, I've kind of put it up there. It's really the goal. I want to get somebody to, again, get attached. And and like you talked about with, if they're not on buprenorphine, I don't think it's possible for somebody who is in early abstinence from opioids to do that. If they're sick, or if they're still really craving opioids, even after they've gotten through the acute withdrawal, I don't think they can do that a lot of times. Some of them can, and some people always stayed abstinent from opioids, but so many patients, it's just not going to be an option for them if they don't have the medicine to help. And then to me, it facilitates that. It really does. It facilitates involvement in recovery for a lot of patients who come to the clinic and then do the 12-step. I really like it when people do both. And I think we're fortunate in our community, because I don't want to speak for all communities because it is different, but in Louisville, we have a lot of friendlier 12-step community recovery to medication than we did. And so I don't know, everybody's probably dealing with different levels of that, because some people will go to meetings and experience, a lot of hostility to being on buprenorphine and methadone, today, which, it is a problem in my view. But again, it's been a problem, and still a problem in Louisville to some degree, but much less. But I like to do, I think it has helped. I do have some groups that I do use with bupe, and I make the patients stay in the group but I've had these groups now going on for several years at the U of L, and the people in the group are really now, they've been together for over 5 years. They're very, very bonded to each other in the group. And it's very helpful. That's not common. That doesn't happen a lot, but I have 2 groups where they've been together for several years, a group of women and a group of men. And, I haven't introduced any new members to those groups in a long time because they're so cohesive with each other. They know each other so well, but I'd probably need to do that.
All right.
Group therapy is is wonderful. It's so useful for so many different behavioral disorders, as well as just in general. There's a really wonderful psychiatrist I've always loved and read a lot of his work, Irving Yalom.
Irv.
Yeah.
So, okay, if you're a group junkie like me, or if you have an interest in that, so the American Group Psychotherapy Association, which is Irv's home, there's another guy in there named Elliot Zazelle, and Elliot has a YouTube series called Group, and it's people in group therapy, and it's pretty accurate about what would happen in a interpersonal group, very similar to Yalom style. And it's really good. And of course, it happens during COVID. They do 2 seasons. The second season is sort of a Zoom group, but the first one is Elliot. Elliot is, I think one of the best group therapists in the country. I'm a little biased, but he's really, he does the modern psychoanalytic kind of group, but it's a great interpersonal group to watch. And it's one season. They were in the room together prior to the pandemic, and it's really good. It's on YouTube. You just do group ! if you want to watch that.
Okay, John, can you look that up? Oh, awesome. John, you're so on top of things. He knew I was going to ask him that.
I got it. It's there.
You can use it to teach group too, if you want. If you want to teach the kind of psychodynamic interpersonal group model, I think it's really good. I mean, it hits all the things that happen in the group, or the kind of things that happens.
I think it's great. There's I just recently reread one of Yalom's books that's meant for patients as well as providers, future providers, called The Gift of Therapy. It's like 60 different reasons why therapy works. And like one of the things like he was talking about was like that, I mean, even like psychiatrists have therapy, like they have therapy, they can have their own groups, like doctors can have their own groups, lawyers can have their own groups, like just that what you were saying, Chris, earlier, just about how humans need connection. I think it's everyone. So, but you know, really important for people that really struggle with relationships and trauma and all that. So.
Yeah, I mean, for our patients and for these patients to connect to somebody has been dangerous, right?
Right.
So you don't, so you have to be careful about that. Just getting very personal with people is, to them can be really, really difficult, and how they come into the clinic is, and of course we're talking about, and Thomas saying about, how everybody in the system, interacts with the person, and that can really be important. He's in admissions and other people are in other areas of the program, and they're all encountering people along the way. And that all is really important, right? And those are all ways that people attach and connect and interact with the system. And, treatment is happening even in those, in our clinic too. Our patients get attached to our front office staff. And I have to watch that, and I have to monitor that a little bit just to see how that's going. Usually it's going pretty good. My front office staff is pretty good about making sure they're, but I also got to protect them, make sure that that's being monitored appropriately and see that that's hanging. But they're pretty experienced now and handle it really well. But it becomes very therapeutic in a way when they interact with the front office. That's important. But.
Yeah.
All right, Chris has got a question.
I have two, but the one I put in the chat, since we were talking about, interpersonal groups, and I just know in previous work, it was actually quite difficult to find individuals offering an interpersonal based style group. And I don't know if either of you are aware of resources to try to help people find those that are offering the groups, throughout our Wave 1 communities or not, but I think that could be really helpful. I've got another question too, but I'll wait.
Well, right now, because of the pandemic, if you are a professional, I'll speak to it's easier to speak to everybody here and the professionals here. You could do an online group with people from across the country, and online groups are more popular than ever. And it is really challenging to find an interpersonal group because it's hard to get patients to do that and stay with it, and enough patients to, have ongoing groups. So it is challenging. And I know who's doing groups in Louisville right now like that. I don't know about any other place. So I don't know if that would be very much, but if somebody wanted to contact me in Louisville about calling somebody who does group therapy and does interpersonal group therapy, I know a few people here in Louisville who do that. We do have, Tony Shepard is a psychologist in Louisville who is the chair of the registry for international group psychotherapy. And so is for the board certification in group psychotherapy through the AGPA. The actual chairman of that lives in Kentucky in Louisville for the whole international organization. And I suspect he'll probably be that for a long time. He is a child psychologist who does a lot of groups with children. But he's always interested in helping people who are interested in learning more about group psychotherapy and getting trained in it. But, I don't know. That's all I got about that.
Great, thank you. Actually, just bookmarked a page about them to look it up later. So thank you for that. My second question is thinking about folks here that may be working with a client in levels of care and thinking about a mental health crisis. So for instance, they are suicidal or something where it might be a level of care where it may be inpatient, but it's mental health related care. And if they're on MOUD, how to try to help collaborate and coordinate that treatment to sustain MOUD, because I could see where that might be something that comes up with clients that could be challenging.
So there are programs here in town in Louisville in psychiatric hospitals where if I have a patient who's on Suboxone and they need to be hospitalized, I can't send them to that hospital because they're not going to continue their Suboxone, which is really, really bad. Just say that. That's the best. That's probably the nicest way I can put that. I think that's, that's terrible. And we don't need to we shouldn't tolerate that. And that's substandard treatment at this point, but that goes on a lot. And so finding programs that are addiction treatment that will not stop people and detox them from buprenorphine, that has kind of substantially decreased, but only in the last 5 years, in my experience here in Louisville. And I think we've had more and more programs who are doing it. Part of that isn't completely some of these psychiatric systems' fault, in that they are dealing with, for example, they're staffed by private psychiatrists in the community who aren't waivered, and then who aren't comfortable continuing it, even though they could without a waiver. They're not comfortable doing that. They're ignorant of it. And so if I have a patient that I want to do that with, I'm calling the facility. I am using connections that I have in the community. I'm asking them to, do that. If they're not comfortable, I want to talk to them about why and try, I'm fortunate because I'm affiliated with an academic institution, so U of L. So patients come into our emergency room at U of L. We have a 24-hour emergency psychiatry service. And so I'm plugged into that, and they can go to 2 hospitals where mostly that won't be an issue anymore at all. And, but there are still facilities out in the community. There were facilities that have opened up in our community where they opened up initially and stating they were abstinence based and they weren't going to be using buprenorphine. And the reason they did that was, they would tell me behind the scenes, was if we don't do that, we will, nobody will use us in the community where we're at. We're going to be really, they're not going to send patients to us. That's the feedback we've got from the community. They don't want that. That happened in a couple of programs. A lot of those programs have moved out of that, but they were like, we'll only prescribe buprenorphine to detox people. That was a trend for a while. They were only going to use bupe to detox patients. No maintenance treatment. We're not going to start people. We're afraid if we start them on maintenance, I don't know what they're afraid of. But that's obviously changing, but that was a problem. Good question. Next, we'd go on to the next slide.
Yeah, we have a few more slides, but I think we have time for one more question. So I just want to open it up to the group and say, if you have a question that you would like Dr. Stewart to answer, I know that we pressured Chris into asking a few questions.
You may have a comment, right?
Yeah.
You may have if not, then,
So yeah, I'll open it up. Otherwise, we'll do one more question.
Okay, I've got something I just ran into, and I talked to different hospitals because we send people for medical detox because we don't have hospital rooms in our facility, and we send them there. We got people that have been working with our patients that are sending them to us for long-term treatment, and they're making, or they put together an agreement before they send it to us that if they're on buprenorphine, that we'll continue it on the same schedule that they've had them on through treatment and refer them back to them for counseling. Of course, these are people that are generally 2 to 3 hours away from us. But I just ran across it. But it's become one of our standards now, to work with hospitals like that.
So they want you to keep the dose the same. They're afraid you're going to increase the dose too much. Is that what you're saying? They're like, they're concerned about the dose changing and then them coming back on a dose they're not comfortable with, something like that?
No, actually they're concerned about I was trying to detox them down
Oh,
to
take them off
zero.
of it. Oh, that's good.
Yeah.
Oh, yeah, just the opposite. Oh, that's relief. I was worried for a minute. I was misunderstanding. Okay.
And I've
Yeah.
actually seen the thing, but I haven't read all the way through it. I'll probably do that tomorrow night because I'm up tonight. But
That's not a bad, yeah. I think that the trend is, you know, finally headed in the other direction, but.
right. I hope so. Really hope so.
All right, does anybody have any last thoughts? All right.
Thank you. This was great.
Yes, I just want to say thank you to Dr. Stewart for the last 2 weeks, giving us a lot of great information about polysubstance use, the prevalence. So thank you for your time and thank you for all your comments. I'm going to go through a few wrap-up items and then I will let everyone go. Just as a reminder, we do have the KY Open 6-month survey. So in order to improve KY Open, we're looking back at the first 6 months. You can, if you complete the survey, you can enter to win one of 10 $25 Amazon gift cards. Chris put that link into the chat. Also, if you would like to qualify for CME or certificate of attendance, you can do so by going to bit.ly/KYOpen-credit, scan the QR code or the link in the chat. For those of you claiming CME credits, so that would be pharmacists, nurses, physicians, and social workers, you will go to cecentral.com/get credit and you will enter XLS, that code there. I'm going to actually copy and paste again because I put the wrong number there. It is 26, not 25. Oh, Chris did it as well. So you can do that there. And again, I just want to say thank you for joining us, and I will thank Dr. Stewart one more time and Dr. Loflaw for their help with today's Q&A. Thanks, everyone.